Okay.
Okay. It's our first time trying to do this whole going live on YouTube, so I'm trying to figure all that out. But I think we're in good shape. Jessica, you look really good. I super struggle with my lighting. I was just like, I just want to look normal.
Yeah, we've been doing this.
I think we're in good shape. Jessica, you look really good. I super struggle with my lighting. I was just like, that's the live. Okay.
Oh, I was all like, why do I hear you again?
Okay. It's the first time trying to do this whole going live on. Okay, now let me do. Okay, and Jessica, so did you get a bio from Melissa? Did you need any of that?
Am I doing Joel and Jennifer? That's what I have.
Oh yeah, you're introing Dr. C.
Okay. Dr. C, do you have a quick bio?
Oh wait, am I introducing Dr. C?
I think you are.
Oh, okay, yeah, okay, great. Yeah.
Wait.
Stop stressing this out, Jessica.
What? Do we have or no?
No, yeah. I wasn't gonna read your bio unless you want me to.
What bio do I have?
You don't have one. I'm just gonna be like, this is Dr. C. She's the medical director for.
Yeah,
maybe
that's
send
good.
me.
Because I was gonna talk.
Maybe send me a couple of quick like bullets.
Shoot.
Okay.
I don't know. I mean, I was just gonna quickly just say where I worked and where I'm coming from, and then that was gonna be part of the bio since we only have like 5 minutes.
Yeah, perfect.
You know?
Yep, let's do that. Okay. Okay, guys, we're live on YouTube, so that's exciting. And okay, Jennifer's here. Hello?
Alessandro, this is Jennifer. How are
Hey,
you?
Jennifer, how's it going? Really good.
Good.
Are you on your phone? So let me merge this with your video.
I can do my computer.
Merge with audio. And it's Jennifer. Let's unmute that. And then let's merge with video. Jennifer. Okay, Jennifer, you're merged.
All right, thank you.
Of course. Thank you for taking the time to hang out today.
Sure, I'm excited about this. It's going to be great.
Jennifer, this is VP of the Joint Center, Jessica Fulton.
Hi.
Hi.
How are you?
I'm doing well. How are you?
Good.
And this is Dr. Melissa C.
Hi.
Hi, Melissa. Nice to meet you.
Nice to meet you too.
Okay, guys, this is so exciting. Jennifer, have you done a bunch of these since we went to home?
Yeah, we've done about 12 all around COVID-19 for the last, we're up to about 2 a week, and we have about 1,000 people on each one. It's been insane. It's great. I mean, it's really tremendous. So I think it's so helpful to people.
That's amazing. So you're a pro at this.
Yeah, we use it all the time. Yeah, so I'm getting very familiar with, the lighting and the sound. And
I know. I struggle with my lighting. I'm right in front of a window, and sometimes it makes me look like there's a light, and sometimes it makes it look like that complete shadow. So it's just like you're rolling the dice with it.
I know. I've got a window, too, so I try to cover it. Yeah. But Melissa, you've got like the perfect lighting, so.
Oh, but I love all of their backgrounds though. Mine's just a plain wall because I love all the backgrounds.
Yeah. Well, we've started using the virtual backgrounds too, like to put our logo up, and that's been kind of fun. So.
Yeah. I feel like it's tough to light with those virtual backgrounds. Like you really have to have like a professional lighting game to make those look good. Like they're not joking when they say like, think about your lighting.
Right.
Okay, awesome. So we made a little tweak to the agenda. So we're basically going to put Representative Thompson is going to speak a little bit sooner. So he's not so rushed with his remarks because he originally had to jump off right after. Okay. So we put him right after Dr. C's remarks. And then from there, we'll go to Lisa and then kind of go from there.
Well, I'm last, so by the time I talk, everyone will have already said everything. So.
That's right. You're closing the show. That's exciting.
Yeah, so I'll have the easiest part.
Okay, perfect. Okay. 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 So Jennifer, how have you guys been structuring your conversations? Are they more like kind of member briefings, or do our organizations kind of give updates, or have you doing kind of panel style as well?
So we've really gotten rid of slides as much as possible, and we're doing kind of more, some are kind of like Oprah shows.
Yeah.
Like interviews, and some are more traditional panel presentations, kind of like we're doing today. But we usually try to save, a lot of time for questions, because when you have so many people, you get so many questions, and that seems to be really helpful to people, I think.
Yeah.
Yeah. So, and I think it's great to be able to see people on video. I feel like there've been, the PowerPoint thing is so 90s, right?
Yeah. Let me just send a quick email to Joel and Lisa.
Everybody have a nice Mother's Day.
Yes,
And
nice. We had good food and it was nice. This is the first Mother's Day since I've been away from home for 12 years.
Yeah.
So, I'm not always home for Mother's Day. So it was nice to just be with my mom and just chill. We binged Little Fires Everywhere. I don't know if you've started.
Isn't that great?
It is. So
Yeah.
my sister-in-law says it's a lot different from the book, but yeah.
It is. Yeah, it's a lot different. But I love the book. But I
Yeah.
love Reese Witherspoon. She's
I know.
Productions.
Well, we just finished Big Little Lies. I finally watched it. I don't know how old it's been, and I guess we were just needing something. We're like, we need more.
Have you watched Little Women yet?
No.
That's a good one.
Okay.
Like a chick flick.
I need to add that. I've seen all the other versions, and that was one of my favorite books, so I need to add it on.
Yeah, that's a good chick flick, I think, right now.
Yeah.
got it. Admit. Hi, Joel. Welcome.
Hey, Joel.
Hey, how you doing?
Good.
Really good. Lisa is here. And then we've got an iPad 75. Is somebody using that for audio?
Getting Zoom bombed.
It might be, they did tell me that somebody might hop on with Representative Thompson, so it might be somebody from his team setting up the call for him. Yeah, did you guys, good morning. Thank you guys for taking the time to chat with us. Sorry, we've already been having a little bit of a chat and combo and catching up on the weekend. Tonight.
Good to see you guys.
iPad with commit.
Good morning, all.
Good morning. Oh, there we go. It's Commissioner Starks. How are you? Good morning.
Good. How are you? Hello, sir.
Really good. Thank you so much for hanging out with us this morning.
Wouldn't have missed it.
Congressman Thompson will be joining shortly. Okay, great. We just got an update from the Congressman. He will be joining shortly. We've got a couple of minutes. I'm glad that we're all on and we can see your beautiful faces. Okay, perfect. So does everybody have the updated agenda? I kind of sent that out so that everybody can follow along in case there's questions along the way. And let me double check. On my end, this looks backwards, but can you guys read this?
Yeah.
Okay, great. Okay, great. We're going lo-fi with that sign. Okay, perfect. All right, so we'll just wait for the Congressman and then we'll get started. Save that. All right. Sounds great. Okay. Well, the Congressman will be joining us here in a second. So I think 11:30. So let's go ahead and get started. Let me make this go live here, and then we will get started. All right. Everybody ready?
Yep.
Okay. Okay. Awesome. Hello, and thank you for joining us today for this important conversation. My name is Alejandro, and I'm the Executive Director for Hispanic Technology and Telecommunications Partnership. Our CEO roundtable of 16 of the country's oldest and largest Latino civil rights organizations work in coalition to promote access, adoption, and the full utilization of technology and telecommunications resources by the Latino community in the United States. Through our community engagement, congressional education, and by serving as a national voice for Latinos in tech and telecom policy, HTTP member organizations work to support the social, political, and economic advancement of over 50 million Americans of Latino descent by facilitating access to high-quality education, economic opportunity, and effective healthcare through the use of technology tools and resources. Now, before we begin our conversation today, I want to invite our friends who are tuning in live on YouTube to join the conversation by using the hashtag telemedicine for all. That's telemedicine, the number 4, followed by the word all. This is what it looks like, telemedicine for all our friends on Twitter. We will be checking in on Twitter throughout our dialogue today and have set aside some time towards the end so that our panelists can answer some of your questions. As we continue to experience the global impact of COVID-19, our conversation today centers the experience of Latino and African American communities as we begin to navigate new modes of healthcare delivery through telemedicine. As we work to address community needs to increase access and adoption of new digital tools, and we will also be working to interrogate the growing concerns over the privacy of our sensitive information as the world shifts to our new digital reality. Today, we'll be hearing from Representative Mike Thompson, who is co-chair of the Congressional Telehealth Caucus, and FCC Commissioner Jeffrey Stark, along with front lines of medical providers working with historically under-resourced communities of color, as well as health policy and consumer privacy advocates working to ensure that these new digital tools are available to every American and that protecting consumer privacy remains top of mind as we become increasingly more dependent on the internet to conduct critical functions in our everyday lives. Our conversation today is presented in partnership with the Joint Center and their work to improve the socioeconomic standing of Black communities in the United States. We are happy to be joined today by Vice President for the Joint Center, Jessica Fulton. And with that, I will turn the mic over to Jessica. Jessica, thank you for being with us today.
Yeah, thanks, Alejandro. So as Alejandro said, my name is Jessica Fulton, and I'm a Vice President at the Joint Center for Political and Economic Studies. The Joint Center is focused on engaging in research and analysis that promotes the socioeconomic and political advancement of Black communities in the United States. And right now, we are keenly focused on mitigating disproportionate impacts COVID-19 is having on Black communities. We've called for the collection of and access to data on COVID-19 testing, illness, and deaths by race. We're actively working to ensure safe and accessible 2020 elections. And we're identifying and analyzing the impact this disease and economic crisis are having on Black workers, businesses, and students. You can find our work on our website at jointcenter.org, and please sign up for our weekly updates on COVID-19 policy in Black communities. We are excited to partner with Alejandro and HTTP for this event because we know how important it is to first stand in coalition with other communities of color, and second, because we know that telehealth is an opportunity to mitigate some of the structural issues that have led to Black illness and death in this and previous crises. Specifically, my interest was piqued when I saw research from Dr. Sheba George about Black and Latino interest in telemedicine. In a 2012 report, she and her co-authors find that in a focus group setting, both African American and Latino participants perceived advantages to telemedicine, like access to multiple medical opinions and reduced wait times. That said, Black folks in particular were concerned about confidentiality, privacy, and the physical absence of a specialist. Given that these studies were conducted nearly a decade ago, I'm really interested to learn more about telemedicine in today's context. So I'm really excited to learn from everybody that's here today. Alejandro?
Thank you. I echo all of those sentiments, and I really wanted to kind of help ground the conversation today by inviting a medical healthcare provider that works here in Ward 7 in the District of Columbia, and has really kind of seen and been at the front lines of the epidemic, and to have her share a little bit about how they first encountered the health crisis, and then how they worked to transition to telemedicine and the impacts that they've seen with their patient population. So it's my pleasure to introduce Dr. Melissa C.
Hi, good morning, everyone. First of all, thank you, HTTP and the Joint Center, for bringing us all together for this important discussion. I hope everyone and their families are safe and well. So yes, I'm first and foremost a family physician. I also serve as a medical director for Federally Qualified Health Center, FQHC. I'm more recently, as Alejandro said, coming from Washington, D.C., serving patients out of Ward 7, Ward 8, communities largely made up of African Americans and where significant health inequities exist. Today, I am now here in Los Angeles, working for an FQHC, serving a more multi-ethnic community, largely Latino Hispanic population, where English may also not be their first language. So, I'm excited to be here to share our experience in the community health centers and with telemedicine. I mean, this was really a real-time overnight transition and large-scale transformation that, we needed to literally figure out overnight. How do we figure this out, develop, implement, and then start doing this tomorrow? And this was even before we, figured out reimbursement, restriction and regulations were lifted. We just needed to figure it out quickly. The reason we needed to do this was because, as the pandemic hit, I would say early to mid-March, and we had to really think about transforming all of our operations to respond to the pandemic, we realized it wasn't just COVID-19 patients or patients with symptoms presumed for COVID-19 that we needed to address. We had whole panels of patients with existing chronic comorbidities or patients with already scheduled preventive screenings, acute care needs that we just couldn't, turn our back on. So, what we were faced was with how do we continue care? How do we do it safely? Because we don't want to unnecessarily bring patients in and then potentially expose them to COVID-19. So how do we continue care? How do our patients continue to access our community health centers? How do we do it safely? Telemedicine is our answer for that, and it is largely what we are doing today. So this allowed for a rapid expansion. I would say maybe this is a silver lining with the pandemic, in that we were able to fast track this now essential primary path to care. It's how our patients are reaching us. It's how we're delivering care. And this previously may have taken years to do, or the community health centers may have been left out altogether because of, not having the funding or the technology to support it. But we got folded into it. It's here, it's in our operations. It's a bulk of how we deliver our care. So it's here to stay. I don't see it going anywhere. And even in this short time, we've seen a lot of benefits. And as Jessica mentioned, access is something that we are now seeing today has been expanded tremendously. Our patients are now able to access us in a more timely and frequent follow-up visits, because we're bringing care to them. We've eliminated barriers such as time away from work, time away from their families, public transportation, lack of parking. So because those barriers have been eliminated in some aspects, we're now able to conduct more frequent visits. Our patients are not no-showing their visits as often. No-show rates is something that we talk about all the time in FQHC setting. It's something that impacts our bottom line. We've seen rates of 30 to 35% no-show rate in FQHC has been cut down to even 10% today. So we know that our patients are utilizing it. Frequent timely visits is something that we really champion and are excited about. I could have a new diabetic patient. I need to titrate their insulin. I need to meet with them weekly. In the old pre-COVID, we wouldn't be able to do that. They wouldn't be able to take the time. But now I can call them, We can look at their sugar loss because their medicines is right there with them. I can titrate their insulin and set them up for success. So increased access, decreased no-show rate. Another interesting thing is social determinants of health. I mean, this is another level of meeting them where they are, bringing care to our patients. In some ways, we're being invited into their homes directly or indirectly with a video call. So we get a glimpse of their home life, something that, you know, we may not have had the time or consistently been able to do in a 15-minute visit in a clinic. So this is something we're really excited about. I do want to ensure that I don't think this would change or replace the in-clinic, in-person visits. There are a lot of things that we still need to see our patients and want them to come in, especially when it's safe to do so. That's vaccinating our babies, prenatal care, pap smears, that sort of thing. And most importantly, building that trust. We can't, eliminate our in-person visits altogether. Building trust and fostering that doctor-patient relationship is, the most crucial thing to allow our patients to successfully care for themselves. So, in closing, I want to, give time to all of our experts on the panel. Just in considering that telemedicine is here now in our community health centers, I want to ensure that we continue to benefit from this. Our communities aren't left out. They're provided the same protections to privacy, and then also education on how to access telemedicine and the technology that's needed.
Thank you.
Thank you, Dr. C.
Thank you.
I know that you have to jump off because I think it's like your third day at your new clinic in LA.
Yeah.
So thank you so much for taking the time.
Right here on a Zoom call here, but I'm back and forth, so thank you.
She's hard at work. Thank you so much. And please feel free to join us for as long as you can, but thank you again for your time.
So I'm going to introduce one of our next guests. We have Congressman Mike Thompson. Congressman Thompson represents California's 5th Congressional District. He was first elected in 1998. Prior to serving in Congress, Thompson represented California's 2nd District in the California State Senate, where he chaired the powerful Budget Committee. Congressman Thompson is a member of the House Committee on Ways and Means and serves as chairman of the Select Revenue Measures Subcommittee and as a senior member of the Health Subcommittee. Congressman Thompson is a co-founder and co-chair of the Bipartisan Congressional Wine Caucus. He is a member and twice co-chair of the Congressional Sportsman Caucus. He is also a member of the Blue Dog Coalition. And last but not least, Congressman Thompson is a co-chair of the Bipartisan Congressional Telehealth Caucus, which is why we're so honored to have him here today. Congressman Thompson, can you tell us a little bit about the Telehealth Caucus and what Congress is doing to ensure that Black and Latino Americans have access to telemedicine?
Well, Jessica, thank you for a nice introduction. It's always good to be on a Zoom meeting with someone who can make you look good. And your introduction did that, so thanks. It's an honor for me to be with you, and thank you to all of you for what you're doing to make sure folks have access to quality health care, especially important during this pandemic. I think telehealth is extremely important, and that's why I'm part of that caucus, and that's why I helped start that caucus. I got involved with telemedicine back in my days in the state Senate when I represented an area that was largely rural, and we needed telehealth to keep people alive and to save money. And I passed the first bill in the entire country that opened the door to expansion of telehealth. It was a state bill that did away with the face-to-face requirement for reimbursement for healthcare, and I've been interested ever since. I've got story after story of people in my area whose lives were saved because of telehealth, and countless examples of money saved because of telehealth. Now, over the years, things have changed a little bit. It used to be telehealth was important in underserved areas. But the truth of the matter is, in the changing times, telehealth is important every place, even where there's good healthcare coverage. There are all kinds of hurdles to access even for people who have health care and have the means to get to a facility that delivers health care. The working environment, parents having to juggle childcare with their work requirements. It just makes it really tough. And nowhere is that seen more explicitly than with this COVID pandemic that we're in right now. And that's why I work so hard to get provisions of my legislation included in the big COVID bill to allow seniors to have access to telehealth, irrespective of their geographic location. And I have heard countless times since this pandemic has started from healthcare providers and patients throughout my district that the telehealth provisions that we passed in the COVID legislation have been literally lifesavers. And it allows seniors to be able to get health care they need without going outside, without being around other people, without exposing themselves to potential dangerous environments. And it really helps healthcare providers to better manage their caseloads. So this thing has been a win-win, and it helps every community on the face of this earth. So we all need to get a shoulder to the wheel and push to make sure that the inclusions that we're able to get in COVID don't go away when the pandemic is over. This needs to be healthcare going forward. It provides quality, affordable healthcare to patients whose lives will be saved, and it saves dollars for healthcare facilities, for local governments, and for individual ratepayers and taxpayers. So thanks for your interest, and please keep me in the loop, and let's work together to make sure we really grow this thing.
Congressman, thank you so much for your time. I know that you also have to jump off, but we just received a question on Twitter by one of HTTP member organizations, Antonio Tijerino from the Hispanic Heritage Foundation. And he said, as we all know, kind of Black and Brown communities are being disproportionately impacted by COVID-19. And specifically, he wants to kind of elevate or raise awareness about undocumented or maybe underinsured people and patient populations that are kind of disenfranchised as a part of the pandemic, and to just kind of see if there's any kind of effort by Congress to help ensure that undocumented or uninsured communities also have access to healthcare during this global pandemic. I think we might have lost your audio, Congressman.
Can you hear me?
Yep, now we can. Thank you.
Yeah, I agree with you. You know, if your next door neighbor is undocumented and can't get health care and they come down with some communicable disease, just because they're undocumented doesn't protect you from contracting that disease. And it's ridiculous in the 10th degree. So I believe that everybody needs to have health care. The other thing that I believe that telehealth is going to spur is a better understanding that certain populations of individuals are disadvantaged because of their lack of access to broadband. So if you are, and we're going to see a lot of it come about because of this pandemic. But if you don't have access to broadband, you're disadvantaged in regard to receiving health care because you can't access the telehealth stuff. And if you don't have broadband, your kids are disadvantaged from other kids who do in regard to distance learning. So I think this is a real eye-opener, and the greater population is disadvantaged if any population doesn't have access to healthcare, or if any population doesn't have access to the best educational opportunities. Those are all things that will come back to haunt the collective us.
Thank you, Congressman, and thank you again for taking the time to be here with us today and for your ongoing work to ensure that every American has the opportunity to benefit from what we are now seeing the transformative power of telemedicine has to improve the delivery and quality of care for communities of color. Telemedicine also offers us an incredible opportunity to expand healthcare access for historically underserved populations, but it also comes with its unique set of challenges that policymakers are still grappling with, including how to protect patient privacy online and how to expand deployment and adoption of at-home broadband, like you mentioned. I want to now invite Lisa Hayes to our panel to share some insights on these topics. Lisa Hayes is the Vice President, Strategy and General Counsel for the Center for Democracy and Technology, and works across CDT on emerging technology policy issues, including protecting the privacy of unregulated healthcare data, content moderation online, government surveillance, algorithmic decision-making, student privacy, internet access and equity, and election cybersecurity. She has also collaborated directly with companies to help ensure that their policies reflect best practices for consumers and oversees CDT's advocacy in the courts. Lisa, based on that impressive list, I imagine that you are understandably incredibly busy in accomplishing all of this within the constraints of your at-home office. So thank you so much for joining us today.
Oh, well, thank you, Alejandro, for that lovely introduction. And thank you to HTTP and the Joint Center for their leadership in bringing together this really important conversation this morning. Just by way of brief background, the Center for Democracy and Technology, or CDT, is a nonprofit organization with offices in Washington, D.C. and Brussels. For the past 25 years, CDT's team of policy experts, lawyers, computer scientists, and advocates have been working to put democracy and individual rights at the center of the digital revolution. I am so grateful for the work of providers like Dr. C, and to Congressman Thompson and to Commissioner Starks for their work on these incredibly complex issues. We are all benefiting from the developments in technology that allow people to get medical assistance and advice in the privacy and safety of their homes. And as the mother of a fourth grader and a daughter who has parents in their 70s, let me make no mistake about my comments here today. If a member of my family falls ill, I will use any and all tools that are available to help them heal. That said, the tools and policies that we are rolling out during this unprecedented time bear the risk of becoming the new normal. And if that is to be the case, we should be thoughtful about embedding privacy and human values in the systems at the time of their deployment. I wanted to highlight 3 quick points I hope folks in this conversation will think about. First, it's wonderful that people can connect to their doctors via telephone, but as Congressman Thompson mentioned, connecting via video is superior. If you are able to actually see your patients and inspect their concerns, doctors can provide a higher quality of care than they can if they're simply having an audio conversation. But in the United States alone, tens of millions of people lack home broadband access. Rural Americans lack these connections because we have been unwilling as a country to absorb the cost of building out the necessary broadband infrastructure. In more densely populated areas, the broadband infrastructure is available, but it's unaffordable for many, with a disproportionate impact on people of color. President Trump has said that he will sign legislation responding to COVID-19 that includes increasing broadband access. Now is the moment for our government to recognize that internet access is no longer a luxury, but a necessity of daily life, and to build out the broadband infrastructure necessary for telemedicine to flourish. Second, a quick note that not all Internet of Things devices are created equal. If we are using web thermometers and cheap pulse oximeters at home, we need to make sure that there are standards for accuracy and reliability that allow the doctors and the public health officials to rely on the data that they are receiving from their patients. And third, I think it's unreasonable to ask consumers and doctors to become computer scientists and privacy lawyers, especially in the midst of a pandemic. There are breathtaking reams of health data that is being transmitted online that fall outside of HIPAA and that are largely unregulated. Consumers need to know that if they ask a search engine, what is the relationship between COVID-19 and HIV, that query is not going to be sold to a data broker with a suggestion that the person typing the query has HIV. When our military, who is stationed overseas, put on their pedometers to run laps and stay fit, they should not expect those trackers to transmit clandestine locations to unintended recipients. When people gather online for an AA session, they need to know that people are not crashing the meeting and secretly capturing statements made by the attendees. And when a patient talks with her psychiatrist via video and the psychiatrist stores that video in the cloud, the doctor needs to know how to protect that video from hackers. This is too large of a burden for individuals to bear on their own. We simply can't move highly sensitive information online without basic privacy and security precautions. It has never been more important for government and industry to lead the way and to take concrete steps to provide regulations and insights as to how to make this transformation realistic and also safe for all Americans. And I look forward to having more conversation about that later in this hour. Thanks, Alejandro.
Thank you, Lisa, for bringing these important complexities to the table. We know the Black and Brown communities continue to face barriers to access and adoption to home broadband. And our current global health crisis has only exacerbated a lot of those pre-existing structural inequities. We also know that this is a challenge that requires integrated collaboration between Congress and regulators such as the FCC. So I'd like to welcome Commissioner Starks to, I'd love to include your perspective on these important issues. I wonder if you might be able to provide an update on how the FCC is thinking through these issues and share any current programs to expand access to reliable broadband connection, as well as access to critical telemedicine options.
Well, yes, thank you so much to HTTP for the Joint Center for hosting me. And I could not agree more with some of the commenters on how much telehealth is going to play an integral role in our future. Personal background, a little bit on telehealth. You know, I come from a family of doctors. My dad's a physician in Kansas. My older brother is a physician in Sioux Falls, South Dakota, and my other brother's a physician out in Virginia. And each of them has told me about how telemedicine is playing an increasing role in their practice. And how they're able to connect with patients and make sure that folks are staying safe, as well as helping to keep them safe. And so since joining the commission, you know, I have visited a number of telehealth and telemedicines, including a VA out in Las Vegas, as well as visiting with Congressman Butterfield down in North Carolina, and in particular seeing a doctor desert that they have there in North Carolina, where mental health was needed for a number of youths, and seeing how it was a real force multiplier that was able to extend the reach of a mental health specialist who was in short supply. And the fact of the matter is that COVID-19 has laid bare the cruel reality of the digital divide. There are tens of millions of Americans who cannot afford home broadband connections. We need it more than ever for teleworking, powering our economy, for helping our young people learn, but really for our topic here today, in order to access medical information. Just some numbers here, because each of these folks, of course, has a real story. 18 million Americans cannot afford broadband for their homes. That is, you know, simply broadband is too expensive for them. You know, one of the real issues is affordability. We have, in addition to the rural access issue, affordability, because we know that 3 times as many households in urban areas remain unconnected as in rural areas. And so cost is something that I'm increasingly paying attention to. It's something that we collectively need to pay attention to. And so to close the digital divide, you know, the FCC does have programs here, but they are going to need to expand to meet the times. Lifeline is the only federal program designed to help low-income folks get connected. And so it's a drastically undersubscribed program. About 7 million Americans subscribe subscribe to Lifeline. We know that over 38 million, and that 38 million, the denominator there is a little bit old, because we know that more and more millions of Americans are struggling. But Lifeline is a low-income program that is going to need to be updated. We also need to increase the number of minutes, voice minutes, and data with that. E-rate is another program, about a $2 billion program to make sure that schools and libraries get connected. Rural broadband pays for hospitals to get connected. But a couple things that I want to highlight specifically: the Connected Care pilot program is distributing about $100 million to Americans through our Universal Service Fund. The goal here is to focus on veterans, focus on mental health, focus on low-income folks, and it is experimenting with innovative telehealth initiatives that can ultimately, hopefully, be rolled into a larger FCC package. But the CARES Act specifically set aside $200 million for a COVID-19 telehealth fund. $200 million. It is going to rural, non-rural, to educational institutions, community health cares, local health cares, mental health centers, clinics, nursing facilities. It really is helping a lot of communities get connected with telecom services, devices, equipment. And for those that are listening here, money is being rolled out right now to a diverse set of projects. Almost $1 million to the community buy-in community healthcare center in Florida. Another rural one, Greene County General Hospital in Indiana, received about $60,000. Almost another $990,000 to expand video telehealth and remote patient monitoring for Kennedy Krieger Children's Hospital. So there are, including adults with disabilities, there are a lot of ways that the FCC is trying to spur telehealth. A full list of the awardees is available on the FCC website. But this is something where we are in the fight and are going to continue. It is a personal passion of mine, and it is something that I believe deeply is going to help Americans, especially both through this COVID-19 time and then ultimately going forward. So thank you for the time, and eager to hear perspectives from the rest of the folks.
Thank you so much, Commissioner Starks. You know, the Joint Center is incredibly grateful for your leadership on these issues, and we're just so excited that you're there working on these things.
Thank you.
We're going to move to Joel White. Joel White is the Executive Director of the Health Innovation Alliance, a broad-based coalition of patient groups, provider organizations, employers, and payers that supports incentives to deploy health information technology to improve quality outcomes and patient safety, and to lower costs. Mr. White spent 12 years on Capitol Hill as professional staff, during which he helped enact 9 laws, including the Medicare Modernization Act and the Trade Act and the Children's Health Act, to name a few. Mr. White was instrumental in developing the Part D e-prescribing law and the Medicare Modernization Act, and in developing legislation that passed the House to promote the adoption and use of health information technology. Mr. White was staff director of the Ways and Means Health Subcommittee, with responsibility for advising members of Congress and directing staff on all policy issues within the jurisdiction of this subcommittee. Joel, can you talk a little bit about how we got to this place in telehealth, telemedicine, and where we need to go from here?
Yeah, absolutely. So I think first off, we are, our group is absolutely committed to a high value system that needs to be empowered by the free flow of data. And to achieve that, we need a modern health privacy and data framework, kind of aided and abetted by the widespread adoption and use of digital tools in telehealth. And the challenge that we have right now is that we have kind of a lack of data. We have a lack of rules and laws that facilitate the use of technology like telehealth to be able to deliver care where patients are. And then we have what Commissioner Starks just talked about, which is needed investments in the infrastructure that's designed to bring that care directly to the patient. And so I think that the nice thing here is that while the pandemic is kind of an undeniable tragedy, it's really prompted a lot of innovations in care. And I don't think we need to lose ground by reverting back to the old way of doing things. So I think first and foremost, you know, kind of what are the facts on the ground? And I think what we're hearing from a lot of folks that we talk to is that most people in America don't know who to trust about their COVID information. And I think, if you look at some of the reporting that goes on, less than 10% of the notifiable disease reports are in a format that allows for real-time use and analysis. But what we're seeing in the data as it emerges in our papers and our faxes and our spreadsheets is that communities of color are disproportionately affected. In New York, a majority of new cases are from racial and ethnic groups. In DC, we've got 46% of the population is Black, 47% of the population, the infections are in the Black community, but 86% of the deaths are from Black people. I think if we knew this right away, if we had data at our fingertips to be able to assess that situation in real time, it begs the question of how many lives we could actually have saved. And I think the point is we can do better, right? The reports should be standardized, they should be automated, they should be available for public and clinical health. Congress provided CDC with $1.5 billion to partially do this. And I think we need to hold their feet to the fire. The second point I'd make is that we've seen these dramatic advancements in telehealth. Basically, all of the underlying laws in Medicare and in HIPAA had to be waived in order to achieve what we're seeing is really this boom in the availability of telehealth. And that says to me that those laws aren't really effective or doing their job in a modern health system. And so we need to take those waivers and make them permanent. And Congressman Thompson has been an incredible champion here, and he talked about some of those, the geographic locations, the requirement to go to an originating site or the hospital or physician office, things of that nature really need to kind of go the way of the dodo bird and allow telehealth to flourish. And so I think almost every member of Congress is on board with that. There's some concerns around utilization and fraud that could be addressed logically, but really our laws were designed back in the 1990s, and we need to advance 30 years into the future here just to get to current state. And then the other kind of additional reforms that we need in the telehealth space is that we need to create incentives for employers really to maximize these benefits for their workers. And there we need some accepted benefits or standalone telehealth policies. And we need to address clear barriers like licensure and privacy that kind of stand in the way of delivering telehealth across state lines and to different populations in urban, suburban, and rural areas. And I think what that points to is more uniformity, baseline standards of protection for consumers and for providers that ensure that healthcare really gets delivered to the people who need it. And again, I think if we think about who's being disproportionately affected here, that means we need to make these investments in broadband. And where we see this digital divide most acutely is in communities of color, and there's specific areas that we see are really taking a toll in terms of deaths. And that's something that really ought to be addressed through our policy, through our laws. The FCC is doing great work. Congress needs to step up, and the administration has as well. So appreciate being here.
Thank you so much, Joel. I think you raised a lot of really important issues. We're going to turn now to Jennifer. Jennifer is the CEO of the eHealth Initiative and Foundation, a coalition focused on digital health, privacy, and innovative solutions to improve care for patients. Jen leads a team of experts conducting research, education, and advocacy. eHealth convenes executives, researchers, and public policy experts to promote best practices in health technology and public policy. Thousands of healthcare professionals and technology experts attend their national education programs focused on transparency, privacy, artificial intelligence, payment, telehealth, and much more. She is an adjunct faculty member at Millikan Institute's School for Public Health at George Washington University and currently serves as project investigator for Robert Wood Johnson Foundation grant, developing a consumer privacy framework for health data. While in quarantine, she enjoys our husband, 2 teenagers, and Golden Doodle. And I'm a little sad we haven't seen the dog yet today, but that's okay. All right, Jennifer, I'm gonna turn it over to you.
thanks so much. And thanks so much for your leadership today and bringing together such an important group. I want to just echo a lot of the points that Lisa made earlier on privacy, because we are co-leading this Robert Wood Johnson Foundation grant on building a consumer framework for privacy. And I'm not going to repeat a lot of what was said. That's the great thing about going last, is everyone's already said a lot of the great stuff. Our organization provides education and research, and over the last 8 weeks, we've convened about a dozen educational webinars with thousands of healthcare providers, clinicians, and technology experts to talk about how COVID-19, telehealth, telepsychiatry, and social determinants of health, what's working and what's not working, and what we're hearing. I want to just share a couple of points that I've heard. The pandemic has really forced three things to happen, I think. The first is, I just want people to recognize, and we keep saying this, this lightning fast access to care. This would never have happened. Okay, we are witnessing a tremendous shift in healthcare right before our eyes. As someone who's worked in healthcare for 25 years, I can tell you this would never have happened this quickly if not for this pandemic. The incentive was not there. We spent a decade trying to get clinicians to do e-prescribing, to use electronic health records. And the shift of clinicians going online and delivering care through telehealth in, a 2-month period. And not only that, but patients, demanding and going into this access so readily. It has changed the market and the incentives for providers and patients around telehealth in a way that we're not going back. The incentive right now for clinicians is this is the only way you're going to get paid right now for many of them. This is the only way you can see patients right now. It has to be through telehealth for many. And if your incentive as a patient is, this is the only way to see your doctor, and your other incentive is, hey, I'm not going to get COVID-19 because I don't have to go see my doctor and sit in a waiting room. It's really dramatic, and I don't think we can, emphasize that enough. The second thing, and Joel kind of alluded this to a little bit, is, the biggest concern we've heard from clinicians is about the money. They had to waive a lot of requirements to allow this telehealth to take place and start paying doctors to see patients through telehealth. And there's all of this concern from providers that, what's going to happen when the pandemic's over? Are they going to stop paying us this way? Are they going to roll back all of these changes? And I think what we're hearing again and again from providers and payers is, let's be honest, the genie is out of the bottle now. This is happening across the nation, really across the globe right now. This has really changed the table stakes, I think, for clinicians in their offices, for health plans, and for CMS, Medicare and Medicaid. People are now getting paid to get care in this way, and the access that this has expanded to groups across the country is so tremendous. It is going to be, I believe, my personal opinion, impossible to pull all this back. I just don't see that happening. I think we are going to see an extension of many of these things. And again, that's just my personal opinion, not the organization. Again, I think that two things, and this has been mentioned a lot, that the pandemic has really shined a light on, two issues are finally getting the attention that they deserve. And that is the social determinants of health issue. We've been talking about SDOH, as we call it, social determinants, for 2 years, and nobody wanted to talk about this. We've put out papers, we've been on Capitol Hill, and it's been very difficult to get attention for this. And now it's wonderful that I think policymakers and the media are recognizing now that there is, a disparate system here. I mean, there are health disparities, and I think everybody in public health and healthcare has known this for a very long time. It wasn't a big secret to any of us, but finally, I think it's raised awareness of these disparities, and it's existed for years, and I think it's great that that's been brought to light. And then the second area I just want to comment on, and that we've heard this from the commissioner and from the congressman and Joel, broadband. The rural areas, we have a number of different executives that we meet with weekly and hear from, and we need to get more funding to broadband in the rural communities. And it's great that money's been allocated there, but we need more. I mean, if we really want to get these rural communities online, it's got to be more than just a sprinkling in different communities. It's got to be much broader. In the meantime, you know, these communities do not have broadband. And in the meantime, telehealth for these communities really only consists of the telephone part of telehealth. Okay, so it's limited to the phone. So if governments don't have the ability to put a broadband system in the next 6 weeks, then they're going to have to address this through this audio-only access, which is really, in many cases, a patient's-only mechanism or a clinician's-only mechanism to get care to a patient through the phone. And the problem is we need to be able to reimburse clinicians for this care that they're only able to provide through a phone call at a rate that isn't going to disadvantage them, just because their patient isn't lucky enough to live in a neighborhood or a part of the country where they have broadband. So I do, again, commend the efforts and the allocation of those broadband funds, but it's got to be much broader. And in the meantime, let's work on some reimbursement for what's happening in the rest of the country right now.
Wonderful.
And thank you.
Yes, of course. Thank you so much for your comment. I feel like I want to go back to Commissioner Starks because I'm checking on Twitter and I'm getting some more questions from HTTP member organizations. I got one from LULAC, who really asked the question, like, are these kind of programs and services available in Spanish? Are they available to community-based organizations that might want to apply, whether that's a community health clinic that serve a predominantly kind of like Black and Brown community? Are there specific kind of earmarks to ensure that these communities are being connected? Or I guess, could you speak to a little bit about that process, about how those the funding is being allocated and distributed across the country?
This is in reference to the $200 million CARES Act COVID program.
Yeah.
You know, I would encourage anyone who's interested and anyone who is in a community that feels that they could benefit from it to visit the FCC website. I don't personally know. There definitely are not any earmarks. It is $200 million that is set aside to impact communities as best sees fit. But, you know, as I nibbled at it earlier, but this is an emergency. And so communities and healthcare organizations that apply, the money is getting rolled out right as we speak. Folks are applying for this money. And so I would not hold and wait. If LULAC is aware of communities or those communities, I would encourage them to submit an application as soon as they can get it together, with the hope that it can benefit their community and that they can get an award.
Wonderful. Dr. C, welcome back. Do you have any remarks to some of our speakers? I think your audio might be turned off.
No, I mean, I'm sorry I got kicked out, or I don't know what happened, but yes, I echo everything that, you know, everyone was saying, especially what Jennifer just said, that this is something that we know is not going back. So we're afraid, you know, what is going to happen once we return back to our new norm. I definitely believe it's going to be a mix. Like I said, we're not eliminating in-person in-clinic visits once it becomes safe, but now that telemedicine is folded in, it's not going anywhere. What is that going to do, especially for community health centers, our rural clinics? How do we, you know, continue forward and be sustainable financially when we had these challenges even before? So, yeah.
Yeah. So I just got another question from another HTTP member organization from MANA, which is a national Latina organization. And I think this is a question that I think we can open up to the entire panel. And she asked, you know, should communities of color be fearful about how their data is maybe being used as we talk about kind of increased efforts to do contact tracing, as kind of our data is beginning to be collected, used, and shared? And would you advise, you know, providing your personal health information via an app or another method to aid in locating kind of potential like COVID-19 hotspots? So I know that there's a lot of kind of like nuance there and a lot of different layers there, but I wondered if some of you guys might be able to kind of weigh in and kind of give some insight to her question.
Maybe I can level set and then kick it over to the real experts here. So I think, you know, we're seeing these disproportionate deaths in communities of color, not because the virus acts differently from a biological standpoint. It's access to health coverage. It is access to care itself, whether that's through telehealth or physical care. It is housing density and issues like that based on how the virus spreads. And so addressing those issues are going to be fairly fundamental to addressing the disproportionate impact that this is having in those communities. Privacy is a critical issue in those issues, right? And so if we want to improve the public health, we need some individually identifiable health information. And that's kind of the trade-off, right? There's this nervousness or this creepiness that kind of comes with this contact tracing and things that we're seeing in the marketplace. But just recognize that if we have strong privacy protections around that data, we can do more to improve the public health than if we didn't have the data in the first place, right? Right now, we're at this baseline unacceptable situation where we need to improve. And so I think you can make the technology and the apps in a way that really de-identifies at the individual person or cell phone level and encrypts a lot of that data so that you can never kind of re-identify that person. The way I think about it is if I'm sitting at my desk and I've got a weather app on my phone and I get a notice that comes through that says, hey, Joel, there's a tornado about to hit your area, stop what you're doing, go to a basement. My data hasn't been exposed, my privacy hasn't been threatened in some way. It's just someone at, app maker A thought enough of me to say, if your geolocation service is turned on, we are going to notify you that a tornado is coming through. We want something similar in this space so that we can say, hey, we want to notify you that you may have been exposed. Contact your doctor, contact your hospital or lab or public health authority so that we can figure this out. It's not a way to kind of dig into someone's personal health record. So my advice is, yes, we should be all for it, but it's got to have the right privacy protections.
Can I comment on that? I have a slightly different take, Alejandro, if that's okay.
Yeah, please.
I think that there's two issues here. For public health contact tracing, that's really important. And I think that that's a government function, public health function, understanding where the disease is moving. If that's done by a government agency, a public health department, I think that that's important to do. And then you have this whole role that the private sector is playing, that there's a lot of concern about a lot of these apps and how that data might be used. And that's a separate concern. But I think if you get a request from a public health county department or a state department that's trying to see where the disease is and track it, that's a different, and I would not be, certainly I understand there's always distrust of government, these days somewhat, but I think that is important right now in terms of tracking the disease. Would I go put my information in an app right now, not knowing where it might end up, and with not a lot of clarity around privacy right now? Probably not. I mean, I would be a little bit more hesitant about that right now. I don't know if Lisa probably wants to, I'm sure, comment on that.
Lisa always has things to say when we're talking about contact tracing. I mean, obviously contact tracing is good, it is reliable. My concern comes when we're introducing apps and technology that's unproven, and the devil is in the details, as Jen alluded to. There are different types of contact tracing apps out there. Some of them work via Bluetooth, which do not have geolocation devices. So it doesn't know where you are. It just simply knows if your phone has pinged against another phone in the same remote or same general area, depending on how far away it's pinging, and whether you may possibly have been exposed as a result of that. I am more comfortable with that type of Bluetooth contact tracing than I am with geolocation-based contact tracing. The problem is the Bluetooth information actually relevant, and does it actually tell us anything? You can be sitting separated by a glass wall from somebody where there is no chance that the virus is going back and forth between the two of you, and yet your Bluetooth is going to be pinging incessantly saying that you are being exposed. So the devil's going to be in the details in some of these programs and how they roll out. We also need to think about when these programs end. As we're talking about how telemedicine is going to be here to stay and we're undergoing a sea change at this moment, I don't know that we need to grant people, whether it's government or industry, permanent access to our information about who we are in contact with. That seems to me something that should be, if it is rolled out, limited to this pandemic with a clear sunset on any type of recommendations. After we have been COVID-free for 3 months, everybody should be deleting these apps and the data should be destroyed other than for research purposes in a de-identified manner. If the original question here was, if you are in a historically underrepresented community, if you're an undocumented immigrant, would you download some of these apps? Would you trust them? In all candor, at this point, I would not. I don't know where that data is going to ultimately wind up. I don't know how it is going to be used either for future insurance purchases or by different government agencies. We simply don't have the frameworks in place right now that would allow me to have a high degree of confidence to expose my family to a certain level of risk about who I am associating with, where I am traveling, and who has access to that information. All of that said, I am hopeful that this technology can be used and developed in a way that will work. And that if you ask me this question 2 months from now, I will have a very different answer and will be able to say, yes, download it now. I think we're just too soon in the process to figure that out. For those of you online who are interested in this, CDT has launched a multi-stakeholder process, which you can learn more about at cdt.org/coronavirus. But we are going to establish frameworks and best practices and hopefully get both government and industry buy-in to some of these proposals that are floating around out there.
I add to that, I would just say that HIA has convened patients, providers, technology companies, and we delivered a set of privacy principles earlier this year that really say that the protections ought to follow the data. What we have right now is HIPAA, the privacy law, says we're going to protect that data in the people that we've identified play within that law. If the data goes outside of that, if it goes into an app or a third-party user, it's not protected under HIPAA in many cases. And so that's a huge gap here. And to Lisa's point, I think that if you're just kind of throwing your data out there into the world where it can be sold and resold and used in ways to discriminate maybe against you or send you advertisements on things that you don't want to buy anyway, that's not a good environment to put your personal health information out into. So we need a framework, a law. Congress needs to act here to say that data ought to be protected. And that protection ought not, in our opinion, depend on an accident of geography. It shouldn't matter whether I'm in New York, getting on a plane and flying to California. My data should be secure and private in both states, regardless of where I'm ultimately there that day. The point is we need strong privacy protections that apply uniformly, because this data is being used and sent at the speed of light all around the globe, quite frankly. We ought to have one uniform standard that protects this information inside HIPAA and outside HIPAA.
Agree completely, Joel. Thank you for that perspective. We absolutely need to make this decision national. I mean, you can see it right here in the Washington, D.C. region. We've got Washington, D.C., Virginia, and Maryland all trying to struggle with this crisis. The same privacy protections need to cover all of the residents of those states, irrespective of which state they happen to be living in, working in, worshiping in.
100%. So we only have a few minutes left in our conversation. I just want to give a quick plug to all of our panelists. For everybody joining online, please stay connected to Commissioner Stark at the FCC, to the Joint Center, to CDT, to all of our panelists that are joining us here today. I mean, to Joel, please stay connected. They all have incredible resources and are leading a lot of kind of thought leadership to really help us understand how to best protect consumers online, how to protect our sensitive data. And I really encourage all of us to just kind of stay connected and tap into our resources, especially if we're members of the work with community health centers. The Health Innovation Alliance has a lot of kind of great policy frameworks, and they're also a great resource. And as you heard through Jennifer and the eHealth initiatives, they work in collaboration with a lot of various organizations across the country to really, I think, ensure that our voices are at the table and that they are heard. And so with that, I really just want to turn the next couple minutes over to all of our panelists and to Jessica for any closing remarks. Commissioner Stark, thank you for being here, and I invite you to give any closing remarks that you might have for our audience.
Yes, well, I know our time is almost up. You know, I think the, you know, we have covered it here today, you know, but certainly from my vantage point, you know, I have been, so much of my heart breaks around this, but to see the disparate impact on communities of color, on Latinx, on African Americans, so much of our inequities have been magnified, amplified. And so that's on the public health side, where you see the disproportionate number of deaths that are happening for communities of color. But obviously something that I think about and focus on every day, on the digital divide and internet inequality. You're seeing very much inequities that are coming back in a fierce and monstrous way. And so I'm focused on it. I'm so glad to be in a intersecting conversation with a number of the public health folks here today, but this is something that is going to have to be on the very front of the front burner for a lot of us. And thank you for the time, and thank you for the collaboration here.
Happy to. Jessica, you want to send us off?
Yeah, thank you all for joining. This was a really interesting conversation. I'm really excited that you all are kind of leading in this space. I'm very hopeful. I think the theme was like, we are not going back to where we were before. And so I'm really looking forward to kind of what this change creates for Black and Brown communities and for the country as a whole. Alejandra?
Wonderful. Thank you, guys. And remember, telemedicine for all. We want to hear your stories on the ground. And if you have concerns, we'll continue the dialogue online. So thank you guys for joining, and have a great day.
Thank you.
Thanks, guys. Take care.